Hello, everyone. Ben Chappell here, and this is my program overview proposal presentation. The program is called CU Docs Telehealth. CU stands for University of Colorado Medicine. Um, the objectives of the program: managing the care of patients outside the physician office, managing population health, and ultimately decreasing cost utilization, such as emergency department visits, inpatient encounters, and managing ultimately morbidity of patients. The methods: this is primarily driven uh, by remote monitoring of patients in their homes, with some added live telemedicine visits, although these would largely be performed by care management personnel, not necessarily by physicians, providers. However, that is possible if deemed necessary. So these care management visits and care management activities would be focused around follow-up from hospitalizations, ED encounters, coordinating care across the spectrum of care specialists, rehab, etc. Medication management performed by pharmacists to ensure patients are taking the right meds, the right doses, the right times, no interactions, things like this. Health coaching from health coaches so patients can manage their symptoms and their diseases better at home, and some behavioral health and social determinants of health. So we'd have licensed clinical social workers to address these issues. So things like housing, transportation, food, and other behavioral health issues. Who are these patients? So we are looking, at least initially, for the program to focus on Medicare beneficiaries who are attributed to CU Medicine primarily through primary care. These beneficiaries have two or more chronic conditions: diabetes, hypertension, heart failure, asthma, etc. They are Colorado residents, which I'll get into more about that in the legal and licensure section. And these are not patients who are residents of a skilled nursing facility or a long-term rehab, long-term acute care, not patients in hospice. Goals and metrics of the program. So maintaining 70% enrollment and usage rate among that group of patients, and having among those enrolled, engaging them in telehealth services at least one time per month, so about 70% engagement rate. And then some more outcome focused measures of reducing 30-day readmissions to inpatient hospital by 5%, and reducing unnecessary emergency department visits by 10%. The budget for the program. So we're going to have, we've already got $600,000 that is already budgeted for care management resources through the Comprehensive Primary Care Plus program, CPC Plus. CPC Plus is an alternative payment model in which we engage in, where we're kind of moving away from traditional fee-for-service, moving into fee-for-quality, patient satisfaction, reduced costs, reduced utilization. So this is a program that we're already in. We get funding set aside to do these activities, which include care management, care coordination. 600,000 of that is already budgeted for care management resources. We'd be seeking an additional 400,000 to cover, and from the same CPC Plus program to cover more care management resources. We'd be seeking an additional 1 million in new funds for technology and incidentals for a total of $2 million budget. On the revenue side, we anticipate being able to recoup that entire $1 million layout from the CPC Plus funds by our care management activities within the CPC Plus program. In addition, we anticipate $1.2 million in split DRG penalty savings. So, hospital systems, if they have too many 30-day readmissions, so patients admitted to the hospital, they're discharged, they're readmitted for the same thing within 30 days. If hospital systems have too many of these, they get penalized on all of their diagnosis-related group billings. If we can avoid this through the efforts of the program, we're anticipating entering into agreements with hospital systems to split these penalty savings, so potentially $1.2 million from that, and a lowball conservative estimate of $3 million annually in CPT billings of telehealth services, remote monitoring services around care management. So for a total of $5.2 million in revenue. What's our technology platform? So for live video encounters, we are going to use our existing electronic health record, which is Epic functionality. So within Epic, we have MyChart, which is essentially the patient portal. Patients can log in and see their health information, but also there's other functionalities such as initiating or requesting telemedicine visits, and these visits then kind of take place, if you will, in the framework of the MyChart application. And then additionally, contracting with Validic Mobile, third-party vendor for remote monitoring devices. So this would be an application that patients could download on their devices and sync up to their Bluetooth-enabled monitoring devices. So your blood pressure monitors, your glucometers, scales, spirometry devices, what have you. Anything that's Bluetooth enabled can be synced up to the app and the readings automatically uploaded. But even if patients don't have Bluetooth enabled devices and don't want to get them, there's functionality to essentially take a picture of the readout and digitize that information, normalize it, and have it within the Validic Mobile platform. And then the Validic Mobile platform would aggregate and normalize this data and interface with our existing EHR to have the data in discrete places available for monitoring and care management activities. So some licensure issues. So the program is based out of Colorado, out of the Denver metro area. The closest state border is Wyoming. So we look into what are the cross-state lines licensing issues. So for physicians in mid-levels, both Colorado and Wyoming participate in the Interstate Medical Licensure Compact, which makes it a bit easier and less resource intensive to obtain cross-state medical licensure. For nurse case managers, nurses, there is fairly robust interstate reciprocity agreements. For pharmacists, between Colorado and Wyoming, there's a modified reciprocity agreement, which makes it fairly easy. Pharmacists just have to be practicing in their home state for at least 1 year and pass an interstate jurisdiction exam. Unfortunately for licensed clinical social workers, there is very little in the way of cross-state reciprocity. For these reasons, because there's all these moving parts, and also because analysis shows us that only 0.2% of the population that we'd be looking at are Wyoming residents as opposed to Colorado residents, we are anticipating to exclude those patients, at least initially, from the program, just because there's just too much going on. And then other legal issues. So obviously, malpractice does typically cover telemedicine and telehealth services. Colorado is a mandated malpractice state, so all of our providers have malpractice. For data monitoring liability, there's certain actions that we need to take up front to ensure that patients are aware that this is not an acute hospital or emergency medicine situation where the data that's being monitored is monitored very closely and 24/7. That is not the situation. Care management does not really need that sort of acuity of data monitoring, and patients will be made aware of this and of course asked to follow up with emergency services, 911, as needed if they are in an emergency situation with their health, and not rely on, oh, my data is being monitored by a care manager somewhere, so I'm okay. No. And besides that, the malpractice insurance would basically cover providers along those lines with the data liability. And finally, there of course are HIPAA and privacy concerns. Telehealth is still under the umbrella of HIPAA. So the Epic EHR systems and any CU Medicine systems are all HIPAA certified. And then the Validic Mobile, the third-party vendor, is also conducts their own security risk analysis and is HIPAA certified. All right, thank you so much, everyone. Bye.